Evening all. Today I want to discuss something about the anesthetic management of ECT. ECT means electroconvulsive therapy. So electroconvulsive therapy is a treatment for severe major depressive disorder and other psychiatric conditions. So what they will do, they will induce a seizure in this severe depressive patient or severe psychiatric conditions. With one of these conditions, they will effectively reducing the symptoms. By inducing seizure, they will reduce the symptoms of depression. So it was ECT was introduced by Surlett and Binney in 1937. So it is the induction of generalized seizure by electrical stimulation on or both cerebral hemispheres. So our objectives are, so what are the indications of ECT? What are the contraindications of ECT? What are the goals of anesthesia for ECT? What are the physiological changes that will occur during ECT? What are the equipment required for the ECT? What are the personnel required for the ECT? What are the drugs that we'll use during ECT? And how to administer anesthesia during ECT? What are the complications of ECT? So indications are pharmacotherapy resistant depression, catatonia, and bipolar disorder, other psychiatric disorders, neuroleptic malignant syndrome, and especially in pregnant patients when medications can be harmful to the baby, then they will be the ECT. And treatment resistant epilepsy and Parkinson's disease, depression and tremors, and neurotic syndrome. These are all the common indications. So let's see some contraindications for ECT of pheochromocytoma and elevated intracranial pressure with mass effect at baseline are absolute contraindications. And patient with myocardial disease and cardiac arrhythmia and bleeding disorders are relative contraindications for the ECT. So what are the goals of anesthesia for ECT? So one thing is to provide the hemodynamic stability to the patient, to provide the adequate amnesia, and to provide the muscle relaxation, that is adequate muscle relaxation to allow for effective patient treatment during the ECT. There are the three goals for anesthesia. So what are the physiological changes that will occur during ECT? During ECT, a seizure is induced by an external electronic device when the patient is under general anesthesia. So this results in a generalized tonic-clonic seizure with a duration that is very good. Seizures causes profound autonomic nervous system activity. This profound autonomic nervous system activity is the main problem, main thing for the complication of ECT. So in the profound autonomic nervous system activity, first what happens, the parasympathetic nervous system is activated. That results in a possible bradycardia, even sometimes asystole also. But the bradycardia is typically short-lived and followed by the sympathetic surge that causes the hypertension tachycardia. The sympathetic stimulation can last for anywhere from 5 to 10 minutes after seizure has been induced. The parasympathetic system will be activated, but it is short-lived. But sympathetic system will be long-lived. So more problems occur due to the activation of the sympathetic system during ECT. So the effect of seizure causing parasympathetic surge increases the risk of myocardial ischemia if the bradycardia is severe enough for too long period of bradycardia is present. Any of parasympathetic surge is very short-lived. In some conditions, if bradycardia is too long, risk of myocardial ischemia is more. So glycopyrrolate and anticollagen medication can be given to counteract the parasympathetic response, such as increased elevation bradycardia. But unfortunately, the administration of anticholinergic medications cause opposite effect of producing tachycardia, because the duration of action of glycopyrrolate is long, but the parasympathetic surge duration is very short. So what happens? The effect of the glycopyrrolate that will fall on the sympathetic surge also, which is cause exaggerated sympathetic response. So the sympathetic surge. During the sympathetic surge, prolonged tachycardia, hypertension, increased risk of cardiovascular events due to increased myocardial demand oxygen consumption occurs. This sympathetic stimulation in the seizure itself can cause an increased cerebral blood flow and increased cerebral metabolic rate of oxygen, resulting in increased intracranial pressure. So this causes increased intraocular pressure, intragastric pressure also. So esmolol can be used to blunt the sympathetic response, because this sympathetic response will be present for 5 to 10 minutes. So we can use the short-acting beta blocker like esmolol, so that it will act for 5 to 10 minutes. The effect will be immediately reversed. Patient can also have post-ictal states with the stroke-like symptoms of cognitive agitation, which can confuse the clinical picture, as they are also recovering from the general anesthesia at the same time. So equipment, the American Society of Standard of Care of monitoring for the patient under general anesthesia includes the monitoring of the heart rhythm with an ECG and monitoring of heart rate and oxygenation by the pulse oximeter and ventilation, blood pressure. A tourniquet should be used one of the patient extremities when the muscle relaxation from affecting the extremity, which allows the monitoring the effectiveness of the portion motor portion of the seizures. What they will do, they will apply a tourniquet usually to the lower limbs, so they will inflate the BP curve above the systolic pressure, so that blood flow it won't go to the that site area. But they will monitor the seizure duration. And other monitors are electroencephalogram monitors, a process ECG, and monitor the state of the brain during seizures. And emergency equipment, airway equipment should be readily available. There is a difficult intubation card. A soft bite block is provided in the oropharynx to prevent the tongue and tooth injury, as a generalized epileptic seizure has been shown to cause such trauma even in the setting of muscle relaxation. And a bag and wall mask and simple oxygen face mask should be available to administer the oxygen. And a suction device is must, because the lot of secretion will occur, aspiration more chance. So we have to see that the suction device must present during the anesthesia of ECT. And finally, the ECT machine which deliver the shock. So who are the personnel? A psychiatrist, a nurse who assists the psychiatrist, and a trained anesthesiologist. These are the three personnel who has to be present during the ECT. So regarding the administration of anesthesia, so we have to do the pre-medication like anticholinergic acid, glycopyrrolate, and atropine are often given to antagonize initial parasympathetic disorder. But the glycopyrrolate is more useful than the atropine. So glycopyrrolate, they will 0.01 milligram per kg is preferred and administered either intramuscularly at least 3 minutes prior to schedule the procedure or intravenously just before the injection, injecting the induction agent. It may increase the likelihood and severity of the bradycardia systole, and it will decrease the risk of aspiration due to the vagal effect of ECT. So they may be particularly useful in patients who are receiving sympathetic blocking agents such as the beta blockers, to whom seizure threshold has not yet been established. And beta blockers such as esmolol and labetalol, esmolol 1 milligram per kg, labetalol 0.3 milligram per kg, can be used to attenuate the sympathetic response. Sympathetic response of surgery, systolic pressure, and heart rate. Esmolol has a lesser effect on the seizure duration than the labetalol, so esmolol is more preferred than the labetalol. And calcium channel blockers and alpha-2 agonists can also be used. The clonidine and dexmedetomidine, that is 1 milligram per kg over 10 minutes before injection of anesthesia, they control the blood pressure without affecting the seizure duration. So medication that increase the morbidity, that is lithium, or decrease the efficacy, benzodiazepines and anticonvulsant of ECT should be appraised. So oxidation, many patients became hypoxic and cyanotic with loss of sphincter control with the practice of unmodified ECT. So the introduction of modified ECT with muscle relaxation results in a reduced oxygen requirement. Despite this, however, cerebral oxygen consumption increased almost 200% during the seizure. That's why pre-oxygenation is very important during the ECT, because cerebral oxygen consumption has increased 200%. So it is therefore a standard recommendation that the lung should be ventilated with 100% oxygen at the rate of 15 to 20 breaths, beginning approximately 1 minute before induction, continued until the resumption of spontaneous breathing. At least 3 to 5 minutes is preferably given. So the hyperventilation may prolong the seizures. We have to avoid the hyperventilation. So technique of treatment after pre-medication and pre-oxidation, the intravenous anesthetic choice is administered followed by hyperventilation bag and mask to induce the hypocapnia, which lower the cerebral blood flow and reduce the seizure threshold. After general anesthesia is successfully induced, a muscle relaxant is to prevent the myalgias and the musculoskeletal injuries during the seizure. This is the tourniquet. They will apply that distal end of the limb. They will inflate the BP curve for more than systolic pressure, so that the drug which are what we are giving, they will not enter into this area. But the stimulus after giving the ECT, you can see the convulsions. There is the convulsions at least they should be present at least more than 15 seconds, not more than 75 seconds. So that's why a tourniquet is commonly applied on the lower limb to block the muscle lax from reaching the area. This helps to monitor the portion of the seizure and allowing the personnel to observe the tonic-clonic activity of the lower limb. And technique of treatment, a soft bite block is then placed to prevent the patient from developing oral injury, like a soft bite block or during seizure. The electrical stimulus is then administered to induce the seizure and is monitored by the EEC. So goal of the seizure is at least around 25 to 75 seconds, but not shorter than the 15 seconds. At least the seizure should be 25 seconds. You can see the effective ECT, you can see the tonic-clonic contraction of the toe at least 25 seconds. The more prolonged seizures can be desirable if the patient has been had a ECT that were less than the 50 seconds in the past. The patient is then recovered in post-anesthesia unit having their neurological status and hemodynamic monitoring until it is appropriate for them to return home and then to their assigned hospital rooms. So an ideal induction agent should have a short half-life with a rapid onset of recovery, and it should be maintain hemodynamic stability, and it should not interfere in the seizure duration and seizure threshold. So these are all the different drugs that will use induction agent: the methoxytol, etomidate, propofol, ketamine, and sevoflurane, and muscle relaxants are succinylcholine, and non-repolling like short-acting non-repolling muscle relaxants like rocuronium can be used. So combination of induction agents that now recently they are using the ketamine and propofol, the ketofol and dextromethorphan. The combination of ketamine and propofol dextromethorphan mixture can be used as an alternative induction agent which overcome the disadvantages of the individual agents. Propofol combined with the ketamine anesthesia might be the technique of first choice of patients with the depressive disorders undergoing ECT. So ketofol dex, that means ketamine and propofol and dextromethorphan combination has advantage in the form of increased seizure duration, lower incidence of agitation, and more patient satisfaction, and acceptable decrease in heart rate and blood pressure when compared to the ketofol and without any significant side effects. So ketamine, propofol, dextromethorphan combination is the best. So these are all the different agents that will use induction, that the descending order of ability of increasing heart rate. So propofol will decrease, ketamine will increase heart rate. The induction is in descending order of ability to decrease the blood pressure. So propofol will decrease the blood pressure and ketamine will increase the blood pressure. These are all the inductions and the descending order of seizure duration after the reason. So etomidate is not interferes, propofol interferes, and induction agent of the descending order of cerebral metabolic rate of oxygen reducing ability, and this is the induction agents in the descending order of cerebral blood flow and ICP reducing ability. So propofol, ketamine it increase and propofol decrease. Induction agent with the descending order of emergence time is so ketamine to the sevoflurane they will emerge very fast. So prolong the seizure duration. So induction agents such as methoxytol, propofol, and etomidate, they are combined with a short-acting, highly potent opioids such as alfentanil and domefentanil, but not fentanyl to increase seizure duration. Another useful agent to augment the seizure duration is moderate hyperventilation. Approximately 20 breaths per minute with end-tidal carbon dioxide should be around 30 minutes. Hypoventilation, hypocarbia that will augment the seizure. It is given immediately after the succinylcholine is injected and continued with a break of stimulus delivery until the seizure duration is achieved. So methoxytol is considered gold standard for the induction of anesthesia for ECT. It is a barbiturate that stimulates the GABA receptor, which are the main inhibitor receptors of brain. But methoxytol produces anesthesia across 4 to 7 minutes short acting, which is ideal for ECT. It does not affect the seizure threshold compared to the propofol and does not shorten the seizure length. Methoxytol can cause a moderate cardiac depression, which helps counteract the sympathetic surge of the seizure. The initial dose of methoxytol is 1 to 1.5 milligram per kg, but nowadays methoxytol is not available in all places. Second drug is etomidate. Etomidate is a unique drug that also works by activating the GABA receptors. Studies have shown that it tends to produce a long seizure compared to the propofol. Etomidate does not cause a cardiac depression, so the sympathetic surge tends to be elevated when used as sole anesthetic agent of ECT. So supplementing intravenous opioids such as remifentanil and beta blocker like esmolol to inhibit the sympathetic phase is common while using the etomidate. And etomidate is known to cause adrenal suppression and should be avoided in patients with known adrenal insufficiency and critical illness patients. A dose of 0.3 milligram per kg of etomidate is given to induce general anesthesia and lasting around 5 to 10 minutes. Another drug is propofol. Propofol also acts on GABA agonist. However, it tends to shorten the duration. It increases seizure threshold. It is used in ECT as an anesthetic agent with when previous seizures induced by ECT have been prolonged when a rapid onset is needed. Propofol dose is 1.5 to 2 milligram per kg. Second drug, ketamine. Ketamine is an NMDA antagonist. It causes the dissociative anesthesia as well as analgesia. It is often used in ECT. It tends to increase the seizure length and causes indirect myocardial myocardial stimulation, and dose of 1 to 2 milligram typically used to induce the adequate anesthesia. Recovery time is slow and followed with the recovery time is very slow. So sevoflurane is the option for the induction of anesthesia when the intravenous are not available. It has slow onset compared to the intravenous anesthetics. It can be helpful to initiate anesthesia to obtain IV access or when the patient is uncooperative and awake. So when used to short period, sevoflurane has a quick recovery. In systematic review, sevoflurane reduces seizure length more prominently than the propofol barbiturates. Ketamine. Sevoflurane does not attenuate the sympathetic stimulation and to the extent as other induction agents. So the opiates and beta blocks are often used to maintain the hemodynamic stability. Sevoflurane enhances muscular blockade compared to the intravenous anesthetic agent. So it has advantage of attenuating the uterine contractions following ECT. It is used in the third trimester of pregnancy. So CO4 is the only induction agent used in ECT has an advantage. It produces the skeletal muscle relaxation and enhances the effect of the neuromuscular blocking agents. Saxalyf is a preferred muscle relaxant for ECT. It's a short acting. It's a depolarizing neuromuscular block given in the dose of 1 milligram per kg to produce the adequate muscle relax for intubation condition within 13 seconds of administration. Typically lasts for 5 to 10 minutes, 5 to 8 minutes. It raises serum potassium levels after IV administration. Especially hyperkalemic patients should be very cautious. So there is no reversal agent for saxalyfcoline, but typically that is not needed because its duration is very short. So non-depolarizing neuromuscular, the rocuronium, we can use a short acting. The rocuronium will be the 0.6 milligram per kg and it affects loss for around 35 minutes. And if Sugammadex is there too, if any emergency you have to reverse the condition, we can use the Sugammadex when using the rocuronium. Complication, the most common side effect of ECT is headache and cognitive impairment. A seizure that too long can result in status epilepticus sometimes. A status epilepticus is more common. The pre-treatment with the theophylline is used to prolong the seizure. So difficult to mask ventilate and the patient endotracheal intubation, especially obese patient, is one of the more complication. During the requiring PSU, myocardial infarction, ischemic hemorrhage, stroke are possible. So monitoring is very important, especially in the PSU. And cardiac arrhythmias and prolongation, be cautious when you are using sevoflurane ketamine. And patient emerging from anesthesia may also become agitated. Sometimes he experiences the pain. That's why we can use the short-acting opioids. So potential side effects such as paralysis or mania are also possible. So short-term memory loss is also common during the ECT. So for a discussion sake, ECT is a small procedure, but it has so many physiological changes. It will alter the autonomic imbalance that will cause a lot of complication. So while giving the anesthesia, we have to assess the airway because usually the psychiatric patient, they are obese. So difficult intubation cot must be there along with us. And we have to senior anesthesia also we must be there. But at the same time, induction of drugs that should not increase the prolonged seizure. Very short acting muscle relaxation, they are ideal during seizure. At the same time, monitoring also very important after ECT because PACU, the patient has a more complication due to the long effect of sympathetic surge. Sometimes myocardial infarction also occurs. So post in PACU, so after ECT, monitoring is very important. So these are regarding the anesthetic management of ECT.